It's an intracellular gram-negative toxide. That really is what tells you that next statement. It doesn't color extremely well with gram stain. It'll look a little pink-red, but it's hard for them to really denote, so it's better stained with GEMSA, which will turn into a little bit more bluish purple. We're going to talk about four specific rickettsial diseases. One has kind of been shifted to bacterial protozoal type disease, but it's still right now we're slotting it under rickettsial. Q fever is the only one that's different. Okay. So a little bit of path. Generally, it's excreted in the feces of lice and or fleas. Usually it breaks the skin. This one, just like some of the other ones that we've already talked about, will get into your skin and it'll get into your vessels. And they usually live, again, just like some of the other ones, in the endothelial portion of your blood vessels. Now, because they like the smaller vessels, right, fingers, toes, nose, earlobes, you'll notice a little bit more on those affected once you start looking at some of these pictures. But because they proliferate in the endothelium, they will cause vasculitis. And once you start getting vasculitis, you'll start cutting off circulation in some of those smaller vessels, which can lead to some gangrene. Okay. If it goes on without you taking care of some of these things, it can spread to the central nervous system, heart and liver. Real easy. All of these are treated with doxy. Okay? Real easy. All of these are treated with doxy. All of these involve endothelium lining, which will all have basically the same type of symptoms, except for Q fever. Q fever is actually a respiratory type deal. So Q fever, out of these four that we're going to talk about right now, is the only one that's going to be a little bit different. Okay? These are zoonotic. Okay? Animals do carry them. They get them to our little flea, louse, tick friends, and then they give them to us. Okay? The first three have rashes. Q fever, I don't think does. And then diagnosis here is serology or PCR. Okay, keys to this is how do you get it? Okay, that is basically the key to these as you would go through these. All right. We're going to talk about two specific typhus. We're going to talk about Prowazeki and typhi. Okay, and they're transmitted by, this one is transmitted by body lice. It's endemic in Europe, Asia, and Africa, particularly in Ethiopia and Nigeria, where they've had some outbreaks, but for the last 2 decades, it's really been prominent, more so in Africa. And they say it's associated with crowding, because remember, louse, body lice, as you get close to each other, you can pass it to each other, you spray it. If you share clothes, bedding, you can get it that way as well. For the Navy guys, you guys are over in Thailand, right? You guys got places over in Thailand, I think, or at least in that region. Okay, that bottom statement there is specifically for you guys. Doxy may not work. Okay, so at least with azithromycin, it's part of our kit, so no big deal. This is kind of what they look like. Okay, it's an abrupt onset. Okay, so it's going to happen as soon as you get, it's pretty quick once it kicks in. Incubation period is usually 1 to 2 weeks. And then after that time frame, it can kick in really quick. Fever, intractable headache, rash, 4 to 7 days. Big thing to highlight here, okay, that rash, trunk to extremities. Okay, we look at how do we tell these things apart from each other, trunk to extremities for the body louse. Okay, Prowazeki, that's how your rash is going to be. The other thing to highlight is it spares your face, palms, and toes. all right? This thing usually starts off as macules, become maculopapules, and become petechiae. Petechiae, why? Because of the vasculitis cutting off some of the circulation, so it's going to have or cause you some petechiae. Now, we will also talk about Rocky Mountain spotted fever. Okay, Rocky Mountain spotted fever will be the wrists and ankles, and then centrally. So we'll talk about that when we get there, but it is a good way to denote the differences. Right. So on these, you may get some eschar. That right there will probably be the eschar for this guy. This is probably where it penetrated the skin. And then he's got all this petechiae all around here. Okay, you guys haven't done derm yet, so this is probably what we would call a patch. It's greater than 1 centimeter, and it's slightly flat. This over here is what we would probably call a macule. It's less than 1 centimeter, and it's flat. Okay, so here are some of the complications. As you can see, that little baby's hand, he's got some gangrene going on because of the vasculitis and the circulation probably being cut off due to where and how this thing actually affects you and attacks you. If you leave this go on for quite a while, you may end up with some of these other ones. You may end up with some pericarditis, myocarditis, pneumonia. Severe stuff will be the meningioencephalitis, fatal cardiac or renal failure. So things like to live in different places. Skin and adrenal glands are the #1 place for this thing to want to live, and then it'll move on to CNS, and then heart and then liver for this guy as places as to where they like to live. Burl-Zinser, nothing new. The only thing that this is just a relapse of the louse disease. Okay, this is just a relapse. Same thing that happens initially, is just a little bit milder. Okay, it can remain latent in your spinal marrow, lymphoid, and adipose tissue, where it wants to hang out after it goes latent. Okay, so Burl-Zinser disease is just a relapse of the louse-borne disease. Okay, then you may also have a late recidivating issue that can, on average, occur 10 to 20 years down the line, which will be the same thing as a relapse. Even though we don't have it in the system that we can tell anymore, 10 to 20 years later, you may get it again. Okay? And we really don't understand how that works just yet. Okay, this one is murine typhus. All right, this is the other one that we're going to talk about. This one's transmitted to humans by fleas from rats. All right, big thing that you need to highlight here is coastal regions, homeless population. Okay, not just the coastal regions, but most common would be coastal regions and homeless populations. We have some outbreaks here for the last few years in Southern California, Houston, and Austin. Go figure, those are very large populations of homeless people there, all right? Although we have the outbreaks here in the U.S., this thing is a worldwide distribution. Okay, so here, if you look at Texas, this is the Houston area. So up here is the Austin, San Antonio region. Okay, so here it's already telling you it's very similar to the louse-borne. Nothing extremely different. Everything is just a little bit milder for murine typhus. There is no Burl disease, so there is no relapse phase for this one either. Okay, rash is less apparent. Both you're going to treat with doxy. If you treat with doxy, you'll start seeing a difference within a day or so, within a week. If you don't treat this thing, it'll go on for weeks to months until it becomes more of a severe issue. All right. Rocky Mountain spotted fever, or MSF. It's caused by the Rickettsia rickettsii. It's a tick vector by the wood tick and dog tick. It's the Ioxidid family of ticks. You have two different separations. You have some on the east coast and you have some on the west coast. The principal vector on the west coast is the wood tick, and the one on the east coast is the dog tick. We have noticed a decline since the antibiotic doxycycline came into play. If you're not aware, doxycycline really only kicked into the market in the 70s. So doxycycline isn't extremely old. I think it was commercially available, I think in 75 or 76. The other big piece to remember with this one is it's only in the Western Hemisphere. US, Central America, South America all have this type of issue. Okay, endemic areas, South Atlantic, Midwest, basically the Western Hemisphere. But we are seeing bigger outbreaks along some of the US-Mexican border. This is just basically a case where they found some folks that died because the dogs had some ticks. This is the sparse across the US. As you can see, this little area right here is heavy. If you look at the area here, this is really where the Rocky Mountains are. It comes through New Mexico. So now it looks like it's going west. This is an extremely interesting graph. When you look at it, you'll see that the older population basically gets this more than the younger population, right? Just according to these numbers. But then if you look at this next graph, it's the younger population that has more of a fatality than the older population. So something to be aware of. If little kids get this, you need to make sure you act quickly or you give them meds, i.e. doxy, quickly. Don't hesitate, don't wait on labs because it's hard to denote lab stuff for any of these rickettsial diseases. All right, so here are some other signs and symptoms, gastrointestinal symptoms. You may get some skin necrosis where you got bit. Okay, cardiac involvement, you can have arrhythmias, congestive cardiac failure. So don't wait. If you think this is what it is, then go ahead and give it to them. You have to know this slide, all right? So we're going to go over this slide real quick. Day 1 and 2, after your incubation period has come, high fevers and headache, all right? Day 2 to 4 are the important ones because that's where your rash starts coming in. And look, your rash starts wrist and ankles, and it spreads centrally, okay? Day 2 to 4, you're going to highlight something, you need to highlight that. And you can see all the other things that it causes: nausea, vomiting, cough, myalgias, cap tenderness, periorbital, and peripheral edema. Day 5, your fever is still progressing. It's at 104, so it's a high fever, right? And it gets worse. Here, you're going to get worse abdominal pain, but your rash becomes petechial. Okay. And this is where we get the name Rocky Mountain Spotted Fevers, because a lot of these petechiae look like spots across your body. And the other piece you need to highlight here is your palms and soles. Okay, widespread involving palms and soles. So you're going to get the wrist and ankle rash first, and then it's going to spread to the palms and soles and central. Day 7 through 9 is where the rashes may coalesce, so you may have a big giant purpura noted on the skin instead of those spots. Right? At this point, this stuff can actually lead to the gangrene or septic shock or myocarditis or cardiac arrhythmias. Right? So those are the important things that you need to know off of those slides. Now remember, incubation period is 2 to 14 days, on average 7 days. So you'll have 7 days before the person starts getting sick. You'll have day 1 and 2 when you get that abrupt high fever and headache. That's where you, as a extremely smart provider, will start asking questions of where you've been, any tick bites, part of the country, hiking, camping, things like that, so that you can start this thing. Because if you do have an inkling that it is this, go ahead and start the medication. Okay. So all these little spots, this is how it got its name, Rocky Mountain Spotted Fever. It started in the Rocky Mountain regions, and this is what people look like. So that's how it ended up getting named spotted fever. Here are some spots on the palm of the hand, right? There's not tons of stuff that include palms and soles of the feet. This is actually one of them. It's a little kid with rash all over. This is some coalescing of the petechiae with black eschar. This is some vasculitis occurring at the distal extremities. Okay, so don't wait, just go ahead and start treating these guys. Here are some of the labs that you're going to do. These first labs are basically just to see how the person is doing. That'll be your CBC and chemistry. Right? You'll probably see thrombocytopenia, hyponatremia, elevated transaminases. Okay. But other labs that you can do is at the very beginning of this, you can do a skin biopsy. Okay, skin biopsy early during the disease will actually give you what you need. This is a very slow growing bacteria, so doing a culture is not going to really help you much. And usually because it's slow growing, your IgM is not really going to kick in until 2 to 4 weeks after your early stages kick in. All right, so even if you start doing serology on week 1, you may not get a positive IgG. So they say that you have to do multiple checks depending upon if you understand what stage of the disease process you're in. But IgG can start or IgM can start kicking in anywhere between 2 to 4 weeks after the symptoms start. All right. In your very last statement there at the bottom, doxy's your drug of choice. Most effective, it started within 5 days of the symptoms. Okay. Q fever, this is the only one that's a little bit different, right? Because this one can be inhaled or by a tick bite. Okay, so it's a little bit different than some of the other ones. This does occur worldwide. Primary reservoir for these things can be sheep, cattle, or goats. This thing is so infectious that they say that one organism inhaled can cause you Q fever. This thing can live out in the dirt and soil. So if you are downrange from where this is sitting around in the dirt and soil and the wind kicks up and blows it in your direction and you inhale it, your likelihood of getting Q fever is extremely high. Once this thing gets into your lungs, the macrophages try to come and get rid of it, right? So this thing is pretty smart. It dives into the macrophage and it hides. But in doing so, that macrophage goes ahead and pushes out a bunch of cytokines looking for interleukins, and they call other macrophages. And just like in TB, it comes and it tries to surround it. And if it can't kill it because it can't find it anymore, it just surrounds the macrophage that called for help. Now remember what that does when you're doing TB, it causes granulomas, right? So with these things, when they're in the lungs, you'll see some granulomas inside the lungs because of these things. If they become systemic later on, and they go to the liver or other body parts, you may see some granulomas build up in the liver as well. 60% of these people are actually asymptomatic, so that's another good thing. You don't have to worry about 60% of them. So these are a bunch of common places that you may get this. Slaughterhouses, research facilities, livestock farms. Air Force has a great global health engagement team. They go out and they do a lot of stuff around the world with international partners and host nations. So you guys have to think about them going out and being around these people. military, army-wise, we have to look at our civil affairs teams that go out, particularly the vet teams that go out and deal with all these animals when we go do host nation interactions. Just things to think about with this particular disease. These are some of the symptoms. As you can see, most of those symptoms really tell you it's flu-like, except for your chest pain there. And the big deal here is the rash is absent. There's nothing really big to hang your hat on for this one. For this one, because it is lobar, it is respiratory, we will do radiographs. So here are some of the possibilities of what you can get for your radiographs. That multiple segmented opacities, that'll be possibly some of the granulomas that you may see inside of there. You may get some pleural effusion, so you may get some blood in there. Your lobal consolidation, you may get one of the lobes may have some pus or blood or fluid in it. And then linear atelectasis is one of your lobes may collapse. Okay, so you'll note any of those in the radiographs that you take. The other different thing about this is men are more symptomatic with Q fever than women are. Pregnant females usually are asymptomatic. And then this is also based on geographic issues. So over in Europe, the systemic one that's most common is hepatitis. Here in the United States, the most common systemic Q fever is cardiac, okay, endocarditis. Okay, a little bit more. These are the ones that you're going to look for. You'll see some leukopenia, you'll see some thrombocytopenia, hypernatremia. Serology, this one may be a little bit different or harder to diagnose just because it can mix with some of the other ones, and it'll be very hard to denote that that's what this one particularly is. So it does have some cross-reactivity with some of the other ones. You can still do EIA or IFA. If you do have a Q fever panel, the Q fever panel involves both EIA and IFA together. So you check at your facility if you do have it, and that'll make your life a whole bunch easier. And we're not going to do a culture for this one because remember, this one is highly infectious, and we don't want to be doing this highly infectious stuff inside of a lab that cannot handle highly infectious stuff. Those have to be bio level 4 labs or higher. Okay, other quick facts. Mortality rates for Rocky Mountain spotted fever without therapy, 25%. With therapy, 5 to 10. Last-born typhus, uncommon with 12-year-old, under 12. 67% with 50-year-olds. And the mortality for Q fever is less than 1% when treated. Right. Anybody have any questions about that? All right. All right, so the next thing I want to talk about is Lyme's disease. Okay. This is a tick-borne transmission caused by a spirochete, Borrelia species. This one is the deer tick specifically, or the black-legged tick. It's just a different name, same thing. Okay. This wasn't recognized until the 1970s as well. I don't know if anybody here is from Connecticut or the Connecticut area, but over in Lyme, Connecticut, they had let's call it an outbreak, but they had a large group of children that started having childhood arthritis, and they wanted to figure out why. They had a large group of adults that were having arthritis, and they were trying to figure out why this area had such a large number of childhood arthritis and adult arthritis. And they found out that it was Lyme's disease, so they called it Lyme's disease because of the region that they found it in. that it's common in Maryland and to Maine. We used to say it was basically the Northeast, but it's a little bit more than the Northeast. It's the Northeast, a little bit west of the Great Lakes. So here we've got Wisconsin and Minnesota, and then there's some smaller outcroppings out in Northern California. I thought this was kind of a cool picture. This is dark field microscopy. It's one of the ways that they find out if it is Lyme disease, and it's just basically shining some light through the sample, and it shows up a little bit differently in the sample versus the tissue of the bacteria or the spirochete. Kind of cool picture. The surgeon Lyme disease again in the Northeast. Basically, we're starting to do reforestation again. We're trying to fix the stuff that we broke. We're having a larger deer population. The deer population up there is basically the host for the tick. And then some of the folks up there are actually starting to go around. You have vacationers that go up there and go around in their shorts instead of long pants. These things don't jump, they don't fly, they just, you walk by, they just grab onto your leg and they hang on for dear life. Okay. This is the white-footed mouse. This is generally the primary reservoir that carries this little thing. That can spread it to the deer. That's a little deer that carried it around. So here are some of the areas throughout the U.S. that are possibly endemic. So again, back to depending upon where in the U.S. you're going to work, there are certain things that are going to be more populous in those areas. So when you get there, figure out what the most common things are in those areas. In this case, the Northeast would be Lyme disease. You could see a little west there of the Great Lakes. And then your area there, northern California. But then surprisingly enough, in the southeast of Alaska, you also have a group there too. The two specific one, we have two specific ticks. We have the scapularis and the pacificus. Probably guess the pacificus is on the west coast, right? The scapularis is on the east coast. They're the same family of tick, just two different types of tick that cause the problem. So here's your path. Once they feed on something infected, then they come and bite you. Big thing with this, when they bite you, they have to bite you for a minimum of 24 hours. Okay? Minimum. Depending upon who you read, they'll tell you up to 36, but minimum is 24 hours that they have to bite you in order for them to be able to infect you. This stuff doesn't come from them sucking your blood, it comes from your salivary glands. All right, and then we have the two main types that usually cause it will be your nymph. That'd be your little kid stage of being a tick, and then your adult stage. And there it tells you your times. Spring, summer for your nymph, that causes 85% of them, and then fall time, the adult. The big thing with the nymph is that they're really, really small. So you may not even realize that they're hanging on to you or sucking your blood. Remember, these things like to go to your groin area, they like to go to your axillary area, they like to go to your waist area. So if you are checking people, make sure you check those particular spots. They like to go to your butt crack, okay? So make sure you check those particular spots when you're checking a patient, all right? They can attach to any part of the body. Okay, so at least 24 hours of attachment in order for it to really pass on the infection. And of course, it happens during warm seasons. They only crawl, they don't fly. They're usually hanging out the leaves, the grass. As you walk by, you just pull them onto yourself. And they literally put their mouth into your skin to feed. And they are slow feeders. This is what they look like. So this is the male. The male is generally smaller than the female. Female is usually larger. This is a female, and this is a nymph. Okay, these are the ones that cause most of your issues. They have to bite something that is already infected in order for them to infect you. Okay. Here's one that's engorged. There you go, guy. You had a good meal. There's another one that looks a little engorged. Okay, so you may have some false positive or some false negative, just because this one is also very slow growing. This one also takes about 2 to 4 weeks to kick in. And it may have some reactivity with some of the other tests that you do for them. Remember, this is a spiral key, so one of the things that this thing kind of gets confused with is syphilis, because remember, syphilis is also a spiral key. Another disease process this thing kind of gets confused with is lupus. For some reason, when you're doing the test, it can come up positive. So you kind of have to be careful. So what you do testing this is you have to do a confirmatory test as well. And then if you're also endemic to the area, right, particularly the Northeast where this thing is endemic, most of those people have already had this in the past and have gotten rid of it. So IgG, IgM is already in their system. They may carry this for a long time of continuously developing your stuff, which means if you do look for stuff, it'll look like they're positive, even though they're no longer positive and they've been treated for this. Yes, sir. Lupus. So 3 initial bacterial invasions. So you had your, I got the infection, no issues, I could be asymptomatic, I cleared it, I'm good to go, right? Your body probably is making IgG, IgM, no problems. Next time you get it, hopefully it'll help you, right? But if you were to do a test on them, they will come back positive even though they don't have anything anymore because they're probably still developing those IgG, IgMs. Number 2 is the bad one, okay? Number 2, it's actually spread across your body. And there's an invasion in different parts of your body already. And then number 3, it just induces a small immune response, a little bit of bacterial invasion. Your body takes care of it before it actually does really bad stuff. And then it goes away and your body develops your IgG and IgM. But number 2 is the bad one that you need to worry about. All right. So here's your 3 stages. Your localized, or what we call early localized disease, usually happens within days to weeks. Your hallmark for this one would be you're going to get erythema migrans. What that is a big red rash. So let me just clarify this point because many people make a mistake when they don't see a target lesion, a target rash. They'll see, oh, it doesn't look like a target rash. It's probably not Lyme's. That is a big mistake. This thing shows up in multiple different types of erythema migrans rashes. Being, it could be a big rash that's red, solid. It could be a big rash that has some central clearing in it. Or it could be a bullseye or target rash, which is what everyone looks like or looks for when they're saying, hey, do you have a rash? Yeah, I do. Let's take a look at it. And if it doesn't look like a bullseye, they'll just say, no, it's not Lyme's. Not true. Do not fall for that. Okay. Now, when we are doing STEM questions, a lot of times folks like to do, yes, this looks like a target lesion, erythema migrans. Okay, that's kind of a big giveaway for Lyme's disease. But that's only in STEM questions. I'm talking for real. This may present in 3 different ways, and it may not always be a bullseye target lesion, okay, of erythema migrans. But that one occurs in your localized or early stage. In your disseminated stage, or your early, what we call early disseminated stage, if you don't treat it, it'll start spreading in the bloodstream. That'll be your number 2, right? That's the bad one. It can occur from weeks to months, and it can you can start showing multiple erythema migrans in different parts. Usually it's at the site of inoculation, but it can start going in different spots. And then depending upon where it goes, right, it'll cause you neurologic type symptoms. Okay? One of the big ones that it likes is causing you facial palsy or Bell's palsy, and that one can happen during the disseminated stage because it's infecting other body parts. The other big one, like I said, in the United States is endocarditis, so you can end up with cardiac abnormalities. That's all during that second stage, okay, which is why the second stage is bad. And the cardiac abnormalities are usually very specific. Cardiac abnormalities are usually first, second, or third degree AV blocks. So when you're doing an EKG for this, because someone's walking in with chest pain, you may not even realize that it's Lyme's, which you may notice on EKG will be first, second, or third degree AV blocks. When you see that on a healthy person, you need to really kind of ask yourself, okay, why does this person have it? And then you need to start asking other questions, okay? And then you have your persistent or your late disseminated stage, where if it still remains untreated, it can go on for an extended period of time, and it can occur for months to years after that, okay? At this point, this is where you start getting your chronic arthritis. Usually this stuff affects the bigger joints, like your knees, your wrists, and then it has like a little certain pattern, and we'll talk about that, I think, on the next slide or two, as to where it affects, to include more cardiac disseminated problems within the late disease stage. Okay, so your incubation period could be anywhere between 33 to 30 days, but on average 7 to 14 days after the bite. So there's your erythema migrans. So look, it's already telling you 2/3 of people have the rash. 1/3 of people with it may not have the rash. So we have to be careful with saying, oh, you don't have a rash, it can't be Lyme's. Not true, okay? The other aspect to this is because some of the ticks, particularly the nymphs, are so small, you may not even realize that they've already bitten, have taken blood from you, it's been more than 24 hours on you, and left. You may not even realize that. It may go into certain areas, i.e., if you can't see your waistline, or you can't see your groin, or you can't see your armpit, it may have been in there, and you just didn't even realize that it was in there. And you didn't even see a rash, right? And then some of these, when you're talking the later stages, like late second or third stage, are you gonna remember that you had like a rash that went away between 3 to 4 weeks, and just faded away? You may not even remember that you even had that rash. Okay? So we've gotta be careful with that, especially when we're talking later phases, but this is the very beginning, okay? So flu-like symptoms, fever, chills, myalgias, tender adenopathy. But the erythema migrans is the big key for this one, if they note it. Okay, this one looks like a bullseye, right? Real easy. You see a bullseye, probably Lyme's, right? Does that look like a bullseye? All right, that's central clearing, right? So that's also Lyme's. Okay, this is one that's already multiple migrans that are starting to coalesce. Okay, would you guess that that looks like a erythema migrans because they're already coalescing with 2 central clearings there? Oh no, it depends on how astute you are as a provider. Right? So this would be because he's already had it for a bit, so he's already in stage 2. Okay, look at that one. The center looks a little bit redder than the rest, but it just looks like a big red rash. Okay, do you think this person could see the back of their arm? Probably not, so they may not even realize it. Okay, and this thing usually fades away within 3 to 4 weeks, and then it's gone, and then you may get the rest of the symptoms. Okay. All right, so you need to know this slide. Extremely important with this slide is that it can cause you cranial neuropathy. Okay, as you can see, especially cranial nerve 7, right? You guys remember what cranial nerve 7 is? It's the one on the face. It's got 3 branches, right? It goes across your face just like this. Okay, it stops right in the middle, right? So that's a huge aspect for this. 10% of folks get it. Usually, it's unilateral. Usually. Okay? Here it's telling you 25% of that 10% are bilateral. Okay? If you do have Bell's palsy, what we usually give is steroids. All right? We give steroids for Bell's palsy. So when you guys get to that part, I think you guys do that in neuro. That's usually what we do. Okay, I would know this slide too, because as we mentioned earlier, endocarditis or carditis is a huge aspect in the United States as a manifestation, as a systemic manifestation. Okay, so if you look at what it says atrial heart block manifesting as 1, 2, or 3rd degree blocks. So you have to be aware that this is a huge possibility, particularly for your age range that you will probably be seeing in the U.S. All right. Okay, so let's play a game. If you look at the lady on the right, how many people think that she has palsy on the right side? Okay, how many people think she has palsy on the left side? Okay, so half people don't want to answer. Great. Okay. So when we look at palsy, do you remember your cranial nerve check, right? You make them smile, make them frown, make them wrinkle their little head, right? Make them close their eyes. I can't open them anymore, right? So that's what you would do here, right? So right there, they're making her smile, right? So her right lip corner is going up. That means the right side is actually working. That means her left side is not working. Okay, so she has Bell's palsy on her left side. So other things that we look for, you see this little area right here? This is called the nasolabial fold. When you smile, usually you increase your little fold there. So she's got a fold here. So this side is good. Her eye is crunching down a little bit when she's smiling. That's good. So that means her right side is good and her left side is not. Nasolabial fold. Her lip is not up, her lip corner is not up like this one, okay? And her eye is not crunched down like this one, all right? So let's work on this one. Now that you know that aspect, if we look at the lady on the left, how many people think she has palsy on the right side? Okay, how many people think she has palsy on the left side? Okay, we're not rich, so we don't have the cool little, like, things that you can click on your phone. Your thing up in here. So raising your hand is probably the best we can do. So if you look at this young lady, her left side lip looks like it's gone up, her eye looks like it's decreased a little bit, and it's a little bit more difficult to denote nasal fold on her, but this one looks like it's a little bit more crunched than this side. This side doesn't look like it's closed, this lip definitely looks like it's down, right? So her palsy is on the right side, okay? All right. So later disease, weeks, months. Yes, sir.
The second patient, could it be bilateral?
Say again?
Could it be bilateral ptosis?
Could be bilateral ptosis?
Well, if you go back to the last one, if she has left side and right side, right? Or no?
No.
Okay.
Because when she's smiling, she's decreasing her eye. And this side is actually kind of sort of going up. So we're kind of looking like it's working. Usually it won't break out. So if you remember, that cranial nerve 7 goes up to your forehead, it goes across to the tip of your nose, and then it comes down to the half of your mouth. Usually it doesn't affect just V1, 2, or 3. It usually affects all of them because it'll affect the cranial nerve itself, not the individual V's. Yes, sir.
Sir, the one with the V's is the trigeminal nerve. I was under the impression the facial nerve had 5 branches.
Okay, I understand. So this one's affecting that. All right, so this one can affect weeks to months. Arthritis is the weeks to months. That one's the larger joints. Okay. So this one doesn't usually destroy the joint. This one just inflames the joint. All right, so there's a difference there. All right, so when it initially starts, it can be several joints, but then usually it'll go down to one joint. Usually the bigger joint will be your knees, the most common. Then it can spread to your ankle, and then it can spread to your wrists. And then there's your time period, usually your first episode within 6 months of your 3-month migraines appearing. So you've got one that may or may not resolve within a 10-year period. That's what we call the post-treatment Lyme's disease syndrome. With that one, if it doesn't go away, it'll end up becoming chronic and you'll have it for the rest of your life. And that'll be this one right here, your chronic, where you end up with arthritis. You could have some meningoencephalitis, so you'll have some mood, memory, or sleep issues, fibromyalgia. But if you were to do lab stuff on this person would not have any spirochetes at all. They would be resolved. They would literally have no evidence of having Lyme's disease, but this is just a chronic manifestation, status post, that some people actually get. And we really don't know why just yet. They're still trying to figure it out. It's unclear. Okay, thoughts on pregnancy? Pregnant women should be treated not with doxy, right? Or any other tetracycline. Usually we'll treat pregnant women with amoxicillin. This we just put on there because we talked about public health stuff. This is the definition that they use when you start pulling your records, whether they have erythema migrans on them or any clinically compatible late manifestation, for the CDC or the NIH to track this across the country. So I put that on there. So their definition is completely different than our definition would be for signs and symptoms of looking for Lyme's disease. You don't have to worry about that last slide. And then you have labs. ELISA is probably your best bet. You do have to do a confirmatory exam. Your confirmatory exam will probably be a Western blot. And because this is very slow growing, because it's very difficult to harbor out the culture, we don't really do much cultures here. Usually takes a couple of months to grow out this culture. Here's the labs. If you do EIA or IFA, you have to do a confirmatory test with Western blot as your second step to verify. You can do 2 EIAs, and then you can substitute that Western blot if you have 2. That VISIC UPS PC EIA, that one looks for a specific protein on the bacteria itself, so it's a little bit different than some of the other ones. Everybody doesn't have that, so you have to ask your local institution if they actually have it. And here, as we talked about before, the IgG and IgM at a minimum can start taking 2 months. On average, it's 2 to 4 weeks for it to start developing in your body. Okay, so other non-diagnostic things that you can do would be your ECG. You can find your AV blocks, your CBC, just to check to see if there's any infections going on. Your ESR probably elevated because of the inflammation going on. And if you do have swelling of joints, you can always draw the joint fluid and send it off for labs. You need to know this slide. Okay, depending upon what it is. All right, so this one, if you're in the endemic area, treat with doxy. If you have a tick bite but you're not in an endemic area, you don't have to worry about it. If you have erythema migrans and you have noted it, doxy. If you're pregnant, amox. If you have carditis, it will be ceftriaxone IV. Okay. If you have carditis, it'll be ceftriaxone IV. If you have facial nerve palsy, it'll be doxy. If you have meningitis, ceftriaxone IV. Okay. And then arthritis, it'll be doxy. Then we just get into prevention. Hey, avoid ticks, wear your pants down, wear long sleeves. They like to tell people to tuck their pants into their socks. Okay, check your groin, axilla, and hairline if you are going to do inspections of ticks. If you are taking your pets out there, make sure you check your pets. You use repellent like DEET. We used to have a Lyme disease vaccine a long time ago. I think they took it off the market around 2002, but they've got a couple in the works right now. Tick removal. If you don't know how to take or remove a tick from someone, just take a very fine needle forceps, as close to the skin as you possibly can go, try and clip onto his head, and then just pull straight up. Don't wiggle it, don't twist it, don't move it, just pressure straight up. With enough pressure, he'll eventually let go. Okay. Ways to get rid of it, either flush it down the toilet or put it in a bag with some alcohol to kill it. Don't try to crush it with your finger and pop all that blood that's been sucking on. Not good practice. This lady's checking the hairline for ticks in a host nation country. This is what they want you to do. Put your socks over your pants when you're out hiking. Don't go hiking in shorts if you're in an endemic area. If you have pets around the ears, eyes, collar, front of the legs, like your axilla area, between your toes, and same thing with the back of the leg and around the tails, generally where the ticks like to go, because everyone likes and has a specific area or they like to hang out in. Okay, anybody have any questions? All right, let's take a 10-minute break. Rabies is just a viral disease spread by certain saliva, certain animals, bats, cats, wolves, dogs. All right, this is one of the oldest viral infections that we know of. Some of these have been dated back to the 23rd century BC, during the Mesopotamian times, where they've found mummies and skeletons with TB, HSV, and rabies. Plato and Homer used to write about these things, calling it different things. Some of them were very close to what this actually was. Some of them understood that this was actually spread by the saliva of some sort of creature. They just didn't know what it was back in the day. Mr. Gottfried, in 1804, finally made some headway with that and realized that this was infectious and this could be transmitted via saliva. This is 1804. It wasn't till 1882 that someone actually started doing something about it. And if you guys remember Louis Pasteur, right, the dude who made pasteurization so that we can make beer, that guy started working on this. And by 1885, he actually had a working prototype to give, where they had this little kid who got mauled by some, they thought were rabid dogs. He gave it to him, and the little kid survived, didn't get rabies, and we're talking back in 1885. So ever since then, we've been developing the vaccine over time to what it is nowadays. Okay. If you find this interesting, there's a book called Rabid, and it's a cultural history of the world's most diabolical virus. That's what it's actually called. And it talks about its history, the science, and the cultural mythology surrounding rabies, right? Because this has been around since Greek mythology. Some folks, there's a paper that I read that says, and this is a medical paper, mind you, this is a medical paper that says, hey, rabies may be the spur of vampires and werewolves in our past. Very interesting paper. So this thing has infected our culture throughout history, and it's extremely fascinating to me. So some facts. Potential exposure is common, often overlooked. Why do we commonly overlook these? Because that little stray kitten and that little dog that's running around the yard that doesn't belong to you, that you don't know who it belongs to, you guys feed and play with, and little kids go out and feed and play with, and nobody knows who they belong to, they may affect you. Okay, so sometimes it's overlooked. Sometimes it's overlooked because little kids get bitten and or scratched and they don't say anything. Just goes away, and then they start getting some of the symptoms. This is a worldwide epidemic, and it is endemic everywhere, more so in the countries that have no animal control, and more so in the countries where you have wild dogs roaming around, which are the largest spread of the rabies. Okay, so here's the bigger facts. Bats. Don't worry about that avian rabies. We're not going to worry about that nor discuss that. That usually happens in birds, wild birds particularly. Bats can transmit it, but we don't really mess with that stuff. Top 3 animals in the U.S. that spread it: raccoons, skunks, and bats. Okay. Number 1 domestic animal that can spread it would be the cats. Right, so we have had somewhat of an outbreak with skunks, coyotes, foxes, and dogs down in the Texas-Mexico border. And I couldn't pull it up on the local site here because of the web stuff. But how many of you guys have ever gone, or do you know anything about the Monkey Temple over in Thailand? No? Any of the Navy guys? Army guy? So NHP means non-human primate. So there is a monkey temple over in Thailand where the temple is dedicated to monkeys. The temple is actually in the middle of the city, which means you have monkeys running all over the city, particularly in that temple. People walk around, the monkeys come up, sit on you, grab your stuff. So we do see a lot of tourists that come back with possible exposure to rabies due to some of these things. This, and I never knew, that they throw out these chunks of medication for raccoons and skunks to eat in the middle of nowhere to try to decrease rabies throughout our woods here in the U.S. Right? Generally not a disease of small rodents. Usually those guys die real fast. So usually we'll get them from bigger animals like dogs and cats. These are other atypical animals that may get it. So there's a whole bunch of them right there. even domestic farm animals like horses and cows can get it and transmit it to you. So that is a possibility. This is the World Health Organization. Rabies Day is 28 September. Happens every year, and they try to raise awareness to prevent rabies from around the world. So they've got really good posters. This is to evoke an emotional response. Oh. Okay, so here's a map of the U.S. where we have a bunch of rabies issues, and it denotes like the main culprit. So down in that southwestern Texas area between Mexico and Texas, you got the fox. You got the skunk that really oversees most of that. In the north, you got the skunk. In the west coast, you got the skunk. And the east coast, you got raccoons. And down in Puerto Rico, you got the mongoose. And in Alaska, you got the fox. Here in Texas, this is probably that corridor, I think, between Austin and San Antonio, where we got a bunch of caves. And they got that bat bridge over there, so it's probably why there's a lot of bats there. All right, this is extremely important to know, regardless of whether it's on the test or not. This is for your benefit as a provider. If there's a bat in the room and you're asleep or unconscious, you will be considered infected, okay? Period. Whether you've been bitten and you see it, or you haven't been bitten and you don't see it, you will be considered infected, which means you'll have to do post-prophylaxis, okay? Period. That's just the way it is. Whether it bit you or it didn't bite you, you don't know. Some of these bites by these bats are extremely, extremely small. Their saliva, which is what spreads it, also has that numbing issue where you may not even feel it, okay? So that is the standard of practice, regardless of whether you're sleeping or knocked out or unconscious. If they find a bat in the room with you, you need to get post-exposure prophylaxis, all right? Standard of care, that's what that is. Right there, they're showing you a bat bite. I don't see anything, okay? But it's a bat bite. This guy got bitten here. Okay, so a little bit of path. This thing likes the peripheral nerves, so once it bites you, the saliva gets inside it. It tends to replicate in the muscle. And remember, the muscle's innervated by peripheral sensory nerves. So once it replicates enough in the muscle, it moves on and it gets to those nerves. And vice those nerves, it starts going towards your brain. Okay? Now here's the big deal with this. If it bites you close to your brain or to your head, you will become infected much faster versus you get bit in your lower extremity. So the closer to your head, the faster you'll be infected. Okay? So incubation period, short as 5 days, long as 7 years. That's a pretty long incubation period, right? Average 1 to 3 months. There's a little bit of time, but during those months, during that incubation time period, number one, the person's probably going to forget that they got bit or scratched by something. That's number one. Number two, they're probably not going to have any signs or symptoms until after it actually starts. So, some drawbacks of that. Some factors that can spur how fast you may get it is the quantity of virus, right? So if that individual, animal, or whatever it was that bit you, got a good chunk of you, and there's a lot of saliva in that wound, you're probably going to get infected a lot faster, right? More organisms cause you to have a much faster growth and reaction inside your muscles to get to those nerve systems, to get to the central nervous system. Okay, if you got bit really deep and it got into your muscles a lot more than it would be if it was something superficial, it's going to spur a lot faster. As we mentioned before, if it's closer to your head, it's going to spur a lot faster. Okay? During the incubation period, you're asymptomatic. You're not even going to have any antibodies respond, right? Because these guys are hanging out in your muscle cells. So it's really not spurring an IgG, IgM reaction. And then if we're talking 1 to 3 months later, and you ask them about any of this, they're probably not going to remember. I barely remember what I did yesterday. Okay, so here's some prodrome period. Non-specific signs. Okay, you may have some malaise, headache, chills. Right, if somebody doesn't tell you, hey, I got bit by some sort of animal. If somebody walks in with malaise, headache, and chills, probably gonna think it's the flu, right? Fever, laryngitis. Okay, so nothing big. The key piece to this is, hey, you need to have that good history. And then down there where it says paresthesia or pain, maybe tingly, prickly, or itchy at the inoculation site, even after it heals, may be a big one, okay? And right under there it says pathognomonic in 50% of the cases. So whenever you see pathognomonic, it's probably something you need to remember, okay? So acute neurologic, 2 to 7 days. So we have two kinds of rabies. We have a furious rabies and we have a dumb rabies, or paralytic rabies, okay? These right here are furious rabies. Furious rabies are the ones that we see everywhere. TV, here that your friend got bit and went crazy, that's furious rabies, all right? Furious rabies attacks your brain, attacks your nervous system, and you start having agitation, hyperreactivity, restlessness, thrashing. You may want to bite people. Okay, you'll have hallucinations. When you go to the hospital, they'll strap you down because you're so aggressive, right? That's what furious rabies does, all right? Okay, paralytic rabies or dumb rabies is different. Although it's doing the same thing, right? It's going to your brain, it's causing you hallucinations and all these other things. This one is actually affecting your muscles more than furious rabies. The paralytic rabies is actually paralyzing your muscles. It's keeping you from wanting to move. So you may see a lame animal in the street that's kind of cowering in a corner or standing somewhere and it's just not moving, but it's drooling at the mouth. It's probably because it has dumb rabies. It's not wanting to move, or it'll just keel over and lay on its side and not do anything. But the mouth is foaming. And why does that happen? So once the rabies actually hits your brain and it starts propagating in your brain and affecting you, initially your gray matter and then goes everywhere else, right? One of the things that viruses want to do is propagate, right? That's what we want to do too, right? We want to propagate. Or procreate, whatever you want to call it. So once it fills that brain, it understands I need to spread. I need to go someplace else. I need to continue to send my seed everywhere else. So this thing goes back down into your salivary glands. And then it causes your salivary glands to hyperinflate and hypersalivate. And that's why these guys are like slobbering at the mouth. The other thing that this thing does is that it paralyzes your swallowing muscles, right? It keeps you from wanting to swallow. Because if you swallow, then you're going to take in that salivation, which has the virus in it. And the virus wants to go out and live somewhere else, infect other people. So that's literally the way it works, okay? And for the paralytic or the dumb one, the patient's relatively quiet. It's 20% of the cases. their muscles are just broken down and they can't use them. It hurts to move. Here are some physical findings: delirium, restlessness, seizures. All these are all neurologic symptoms, right? So big ones to look at would be your drooling and your hydrophobia. And that hydrophobia is a confused word when we talk about rabies, right? Because hydrophobia doesn't mean they're scared of water per se. It means that it's difficult for them to swallow. Is why they're spitting everything out. And with the aerophobia, if they do get it, it causes spasming on their skin. And usually about 80% of folks get that hydrophobia issues, then you end up with a coma, usually within 10 days of onset, death shortly after your coma. In the US, there's been three people that have survived rabies without vaccinations in the entire history that we've been recording, at least that we know of, only 3 in the US. And I think there's 2 or 3 overseas as well. So lab stuff, that RFFIT, it measures the rabies neutralizing virus antibodies inside your bloodstream. So that's a pretty decent one. So you need to remember this slide. You need to remember nuchal skin biopsy, okay? You need to remember that. And you need to remember that this is the most reliable test during the first week, okay? This one is also slow to spur your immune system response. And because it's slow to spur that immune response, even if I do an IgG or IgM, it'll be very minimal. So your nuchal skin biopsy is your best. You're going to find eosinophilic cytoplasmic inclusions. That's what you're going to find. Those are what we consider negri bodies. Okay? And the negri body is really a characteristic of what rabies looks like inside of a nerve cell. Okay, that's what a negri body is. Okay, so need to know that, especially if you're going to look for rabies in the first week. And depending upon when you catch it, you can submit the saliva, but it depends on when you catch it. And then, of course, if we can always capture the animal, we'll keep an eye on it for about 10 to 14 days to see if it is or it isn't rabid. Those little black things right there, those are what we call neuron bodies. And that little ghost-looking thing, that is actually a neuron. Okay. Here are some differential diagnoses. A lot of these are neurologic. All right, treatment. For optimal results, wash, clean the wound. That is the number one thing you need to do. If I ask you the question, what is the number one thing you need to do after you get bit? The number one thing you need to do after you get bit is wash the wound, period. Okay? The more of that stuff you can get out of your system, the better off you're going to be until you can come in and see somebody, or even after you come in and see you as a provider, right? The solution to pollution is dilution, right? Which means you are going to flush the heck out of that thing, okay? And then while you're doing that, everyone else can draw up your IgG, your immunoglobulin. You can figure out whether they have their tetanus shot, and figure out whether you're going to give them the rabies vaccination after that. But the most important thing that you do is wash that wound, okay? You can do the 2 parts, your passive and active, that'll be your immunoglobulin and your vaccine. Those 2 down there, your HDCV and your PCEC are your 2 vaccines that we have. You need to know this slide because this is actual treatment, all right? So for pre-exposure, okay, primary immunization, it'll be, okay, 0 and 7, okay. Your booster will be every 1 to 3 years. It depends on what you look at, right? CDC versus World Health Organization, and then it really depends on clinical judgment based on what you are doing. If you're a civil affairs team going out, hanging out with animals, doing stuff like that in the middle of the jungle, hey, your exposure is probably a lot higher, which means, hey, you know what? At year 1, I'm going to make sure you do get a booster, okay? Vice year 3, which is what I believe the CDC recommends, okay? And then post-exposure is the more important one, right? Because if you don't have the vaccine, you need to get 4 shots. Day 0, day 3, day 7, and day 14. But if you do have the vaccine, okay, you're only getting 2 shots on day 0 and on day 3, right? So you need to know that. Pre-exposure versus post-exposure. Okay, here's the immunoglobulin. Remember how immunoglobulin works. Immunoglobulin will keep it from propagating, but it won't spur your immune system, okay? That's why you need your vaccine and then your natural body. Both of those two will actually spur your immune system, all right? Don't exceed that 20 international units per kilogram. Why? Beyond that, you start getting more severe side effects, and they want to maintain a low level of side effects. So do not go beyond that. Okay, some further thoughts. Make sure you cleanse the wound. CDC recommends that booster every 3 years. It really depends on what you do, because if you're out there messing with those animals, 1 year will be adequate, right? That's what the World Health Organization actually recommends. So you have to be careful with chloroquine and corticosteroids, right? Because if they're going over there and they're taking malaria medications, and it is a chloroquine type medication, that may decrease the antibody response to the rabies, as will corticosteroids. You can do your vaccine and then you can do your immunoglobulin. They don't want you to mix them, so if you give one in the right deltoid, make sure you give the other one in the left deltoid or the left buttocks. Make sure they're on their opposite sides. Other post-exposure possibilities and thoughts. Consult your specialist. Always consult your specialist for this stuff. Always ask if they've had their tetanus prophylaxis. Okay. If you do notice some sort of infection, right, just go ahead and pre-treat them with an antibiotic. And these we usually leave open. You want them to heal by secondary intention. Things you need to ask during your HPI, kind of animal, circumstances, type of exposure. If you do or don't know whether that animal has had its rabies immunization or not. Okay, so these are questions you need to ask during your HPI. Okay, the other thing you need to ask on there is if they've had their tetanus shot as part of your HPI questioning. Just FYI, if you guys are going to go overseas, I know England and Hawaii are 2 specific spots. They require your pets to have rabies immunization, vaccination, and proof. Any questions? Yes, sir. No, it's one. It's one or the other. Okay. They're both different kinds of vaccines, so it's one or the other. Okay. Aerophobia is once you're infected, when wind hits you, air hits you, it may cause spasming on your skin. Your muscles may go into spasm. That one's not as big as hydrophobia. That one's a much, much smaller group that actually has that. Any other questions? All right, this is the last time we're gonna meet. My office is open to you guys whenever you guys want. By all means, come down. I am in room 2401. I am gonna leave you with this Maya Angelou quote, okay? I've learned that people forget what you said, and people forget what you did. But people will not forget how you make them feel, okay? Why do I say that? I say that because in ID, HPI is a huge piece of what we do. It's like being a detective. You have to ask a bunch of questions, okay? But because you're gonna be providers, okay, across the board, not just with ID, okay? You're gonna see everybody. Some people may be there just because they don't wanna go on the run. Got it, okay? You have to weed those people out, okay? That one person that one day may actually be sick, okay? You need to make them feel comfortable enough for them to actually tell you why they are there. Some people may be repetitive customers within a week, within 2 weeks, within a month. You'll see them like 6 times. Like, okay, we've done all this for you. What? You may have to sit down and say, hey, what's going on with you? How can I really help you? What do you really need? Don't be afraid to do those things, okay? Because if you make them feel more comfortable, they'll open up to you so that you can actually find the truth and you can get what the problem really is, okay? And that'll decrease your workload overall, okay? So that's a plus, all right? So if you guys have any questions of me, by all means, I'm in 2401. Thank you for your time. I appreciate you.